The aim of the ADRIFT study was to look at a very specific question, which is after left atrial appendage closure, when we have a device in a large atrium, a fibrillant atrium, with blood stasis, what shall we do in terms of antithrombotic regimen? And this question has never been evaluated by randomized trials. So we have antithrombotic regimens tested in the big trials, but they have not been evaluated against other options. And this is what we have done in ADRIFT. And for the first time, we have tested NOACs against dual antiplatelet therapy, because most of the patients that who undergo this closure of the left atrial appendage in Europe are patients with contraindications to anticoagulation. So that's what we did. We used low doses of rivaroxaban, 10 milligram in one arm, 15 milligram in the other arm, and we compared this to what is the usual standard in Europe, which is dual antiplatelet therapy. And we found that in this small study, rivaroxaban was able to control thrombin generation much better than dual antiplatelet therapy. And this was the primary endpoint of the study. We looked at other things, other markers that confirm what we had on thrombin generation, and we looked at clinical events. Of course, the study is too small to look at clinical events, but we had two device thrombosis. This is what we want to prevent. We had two device thrombosis in this trial, and they were diagnosed by this core lab, independent core lab, blinded core lab, and the two device thrombosis in these two patients occurred in the dual antiplatelet therapy arm. We had no significant difference between the two arms, rivaroxaban 10 and rivaroxaban 15, on the primary endpoint, and the levels, the average levels, were almost comparable. So that was also the case for the other markers. So actually these low doses performed well, but as well with 10 and 15 milligrams. So when you have a phase 2 study like this one, you tend to use the lowest dose as possible, which is effective for what you have selected. So I would think that 10 milligrams is fine. I don't know what the physicians will do with us, because of course what we need now is a large phase 3 study testing this strategy with NOACs, low dose, especially in patients with prior history of bleeding and contraindication to anticoagulation, versus what they usually do, which is antiplatelet therapy. So I'm not aware of any big study going on. I hope one will be done, but this is a way to just promote this new strategy. What I think is that we see such an heterogeneity of treatments after left atrial appendage closure according to the presentation of these patients or prior history. We see single antiplatelet therapy, we see double antiplatelet therapy, we see warfarin in some patients without a contraindication to anticoagulation. We see NOACs sometimes with the AFib dose. We see sometimes low doses of NOACs. Everything is on the table because we see all these prescriptions without support. So at least for the first time, we have randomized data in a small study saying it's feasible, and actually it worked well for this small number of patients.